Hi everyone, I'm Kath Marshallick. As Jess said, I'm a Senior Analytical Manager at the Health Foundation and I run the Network Data Lab. For those of you who don't know or aren't familiar with the Health Foundation, it's an independent charity committed to improving health and the healthcare of the UK population. And the Network Data Lab sits within our data analytics team or directorate at the Health Foundation. And we're really passionate about using data and in particular linked administrative data to improve the health of the UK population and reduce inequalities as well. So as Jess mentioned, the Network Data Lab is a fairly unique collaborative. It's an analytical collaborative across the UK with five analytical partners, one of which is Grampian and Aberdeen. And the aim is just to bring together these partners across the UK to help address major challenges facing the health and care system. So thinking about major challenges largely from a population health perspective, I guess, that we can use linked data to address. So as I mentioned, we've got 5 partners. We've got Grampian and Aberdeen. We've got partners in Wales, which are sort of largely led by Public Health Wales and sort of a large number of organisations there. We've got partners in Leeds and then Liverpool and Wirral, and then the 5th partner is in Northwest London. And I guess to say a little bit more about the kind of work that we do, as I said, we pick challenges that are sort of key priorities at a national level, but also key priorities within our local partners. And one of the areas where we think the NDL really adds a huge amount of value to the sort of the health data landscape and to sort of the health system as a whole is addressing problems that can't otherwise be addressed using linked data. So what we see at a national level is a real sort of scarcity of data that has been linked across different healthcare systems, and sort of feel like I'm probably sort of talking to the converted here, but sort of recognizing how important it is to be able to follow patients through the system to understand how systems are working together to ensure that the health and care of a population is maintained. So we don't have that at a national level, but what we've seen over time are these just amazing pockets of locally linked data sets that are able to answer these questions. So sort of part of the ambition of the Network Data Lab is to come together across these 5 different partners who have these amazing data sets to try analyze these different problems, gain insights, and then turn them into sort of findings that can be used not only locally, but national policymakers can use to address these key challenges. I think maybe just worth very quickly saying that all the work is underpinned by a sort of strong public and patient engagement and involvement. That feels like one of the core principles that we try incorporate into the work of the Network Data Lab, alongside sort of open and collaborative working. So it feels really important for us to work in an open and collaborative way, to share the work that we're doing openly so that other teams who might have similar interests or challenges are able to take the work that sort of we've done and see if they can replicate it in their local areas as well. I feel like I've been talking for a while, and I'm hoping that gives you a really good sort of quick overview of the Health Foundation and the Network Data Lab. And I'll hand over to Jess to chat a little bit about children and young people's mental health, which is the current topic that we are working on.
So it's a very unusual collaboration. So Health Foundation are our funders, but they're also our research partners. So Seb is an analyst at the Health Foundation who did a deep dive into shielding people who are shielding because they were clinically vulnerable to COVID with us last year. And this year, PPIE across the 5 sites set sort of a broad scope to work on children's mental health. And then we were left to refine what was needed locally by working with patients and by working with clinicians. So our goal at the center, our ambition, why we applied for this grant, is basically we wanted to get more deeply embedded in the local NHS. So right now you can work with NHS data. Anyone can at our data safe haven here that Katie Wild runs. So anyone can do that. We sort of wanted to get even more closely related. So to try to provide something that amounts to like almost a service for the children's mental health care field here. So we chatted quite a bit with their clinical team. And it's interesting, it was interesting for us. So the clinical team felt fairly data poor, like the clinicians on the ground. But we know that NHS Grampian has quite a bit of data. So it was a matter of finding out more what they wanted. So the health intelligence team in Grampian often has huge obligations on national reporting. So they have to do wait times for referrals. They have to do incredibly complicated audits for that sort of thing that goes back up to the national government. This is incredibly important work. But the local clinicians were very intrigued about what we could maybe answer for them more about who was using their service. So there's a good count of beds and wait times and things like that, and perhaps less about who was using the service, because it's just non-trivial to figure out. So that's what the sort of niche we can fill, is linking data to think harder about who's using the service. So Helen Rollins is our analyst for this project in the Safe Haven, and she linked together prescribing records, and that's what Will chat with you about today. Referrals, both accepted and rejected, to secondary care, to outpatient care for children's mental health, inpatient care, hospital care for mental health, and A&E and deaths, I think, actually, well, although we haven't crunched that data yet. So we tried to get a big picture of care in Grampian for mental health. And we've basically just started the analysis. So Will present the first interim results we have now on prescribing patterns. We're currently working, he's finished with that. We've moved on to looking at referral patterns. And so we're interested in how have referrals changed over time, who is getting referred, and how has that changed over time, age, sex, social deprivation, things like that. And then the sort of capstone project we have pictured here is trying to analyze differences in the types of populations who hit mental care in crisis. So people who never saw a GP for a prescription, never were referred to outpatient care, but show up for the first time in their patient journey in a crisis situation in inpatient or A&E. So hopefully we'll have something to share with you that in the new year. But so now Will take you on his deep dive in children's prescribing here. So please keep your questions and let's have a active chat at the end here. Will, over to you. Oh, well, I guess I should introduce you. So Will Ball joined the center in March as a research fellow on the Health Foundation project, and is also just finishing his PhD and is a nurse. So basically a jack of all trades. So Will, take it away.
Well, thank you, Jess, and thank you, Kath, for giving an introduction there to the NDL, the Network Data Lab, more broadly, and to our kind of wider bit of research about children and young people's mental health. So one of the aspects, we have a lot of access to NHS level data of mental health care. What we also have is this reach out into the community side of things, looking at prescribing. So we did a little bit of analysis as a kind of interim output, specifically on the prescribing, and I'll just give you a bit of a walkthrough on that today. So I guess the kind of big problem that we're focusing on really is trying to understand mental health need, and with a particular focus on inequalities for children and young people. And I guess some of the background to this is exemplified by a report from Public Health Scotland that came out earlier this year. They looked at the use of mental health related medicines over quite a long period, so the decade from 2010 to 2020. And that is really interesting and useful, but it's very high level summaries. They're looking at it on a national scale, not anywhere near close to an individual record. But they've found some kind of overarching background trends, which kind of aligns with what I'm going to explain to you later. But so one of the big things they found was that there's increasing usage of mental health medications, particularly antidepressants. They found differences in sex and also a social gradient. So perhaps an expected trend, but people in the most deprived areas receiving more mental health prescriptions than in other areas, and that aligns with national level data looking at people's reported mental health, which also shows that pattern. And we've chosen, so this report was for everyone in Scotland, all around the country, and we've chosen to focus in on children and young people. And that is a national priority. If you look at the Scottish Government mental health strategy, the long-term strategy, that's in there as one of the priorities, as you can see by the CAMHS referrals waiting list reporting that they do, which Jess mentioned. It's also obviously been identified as a priority by the NDL, so all of the sites around the country, that's a common theme that's coming through. And then we can't really not mention COVID-19. I think there's a big worry around the exacerbation of mental health issues during the COVID-19 pandemic, particularly young people whose ability to socialize and get that kind of support is maybe a bit limited. So I kind of need to say that medication prescriptions for mental health needs are obviously only one way that we have of treating those conditions, or helping the people that have these needs. There's other treatments like social, psychological, behavioural, educational interventions, and one of the big issues that we've had really is trying to find sources of data that can tell us a bit more about those alternatives. So what we have that's available to us is prescribing, but just to say that that's only one part of the picture. And then on the left-hand side, the Scottish Government commissioned kind of a public engagement with young people around mental health services, and two of the key recommendations that they have here are to do with prescribing, and that young people themselves see medication shouldn't be the only or an automatic option, and that it should be, consistently, we should be looking at the prescriptions that these young people are having. So the aims of our analysis essentially is three things. We're looking at the prevalence of mental health prescriptions now and in the past. Secondly, we're looking at the characteristics that are associated with these prescriptions. So this is the real value of having that individual level data. We can look at, who are these people that are receiving mental health prescriptions, and what patterns can we see? And then thirdly, looking at trying to quantify the inequalities, particularly in area deprivation. That's kind of quite an available socioeconomic measure that we can look at. So the data that we have on this, we've got medications are recorded because the way that prescriptions are filled in Scotland, it's obviously free at the point of use for people, but there's also a billing system which goes on in the background, so we're aware of recording all of those prescriptions. And there's the thing called the Prescribing Information System, which is reported nationally, and that gives you a record of every single prescription linked to an individual that's been prescribed or dispensed in the community. And we've got data going back from the 1st of January 2012 to 31st of May this year. We're going to link that to the Scottish Index of Multiple Deprivation. So based on where a person lives, that can be linked directly. And then we've also got the National Records of Scotland produce mid-year population estimates, and they cut that by age, sex and SIMD, so we can produce rates. The study population that we're looking at are people who are aged between 0 and 24 at their prescription date. They have to have had at least one mental health prescription, and they have to have been resident in the NHS Grampian Health Board. So we have a subset of the PIS records, but that can include people who travel to Grampian and have a prescription filled in Grampian but live elsewhere.
Will, can I stop you for a minute? Maybe
Yep.
do you just want to say what in the community means?
So in the community is basically anything outside of a hospital. So if you've been prescribed something and you pick it up at a local pharmacy outside of the hospital, then it will be recorded. So it's regardless of where that has been prescribed. If your doctor in the hospital gives you a prescription to take away, and you fill it in the community at a pharmacy down the road, that's recorded. So this is how we're defining mental health prescriptions, and this actually aligns quite closely with the Public Health Scotland report that I showed you at the very beginning. So there's kind of 5 BNF sections. So British National Formulary is a big, basically the Bible of prescriptions, or licensed prescriptions at least. So these are commonly used to help treat people with mental health needs. But there's a couple of notes on this data source. So as I said, PIS is an administrative data source. It's based on billing, essentially. So there's some quirks that come with that I'll explain later on. And also the BNF as a record of medications is a listing of licensed usage for these medications. So it's quite common for certain medications to be used for a different reason than they were licensed for. So there's a little bit of uncertainty kind of baked into this analysis that we're looking at, as we don't have detailed data on the reason for an individual being given this particular drug. But I think in the case of most of these medications, we can say with a reasonable degree of certainty that these are generally given for mental health reasons. This is some of the background trends that we found in NHS Grampian. So it aligns again with what was found at the national level, that there's an increasing usage of these medications. This shows the number of prescriptions, the monthly number of prescriptions for these different sections. And I think you probably agree that for most of these, it's going upwards. I guess probably most obvious of all on this chart is how many more antidepressants are given, or how many more prescriptions for antidepressants are given than for the other types. There's a couple of small kind of issues with the data that are highlighted here. So the blue line, if you look around the middle of 2019 to the middle of 2020, you see this big drop, and this is the administrative nature of this data is really highlighted here. So most of the medications that are prescribed in that blue line are melatonin, which is a sleep aid, essentially. And there was a change in the way that was licensed over this period. So you can see this big drop. That's not a real drop in the number of items that are prescribed for melatonin. It's just the way that they're recorded within the data changed. So it looks like there's a big drop, but there isn't necessarily. And then also, if you're very, very eagle-eyed, you might spot that there's a couple of months recorded in here that don't have a dot. So we found in the middle of 2019, at the end of 2020, there's a couple of months which we don't have records for, which I'll explain a little bit more just now. So this is kind of an annual overview of the number of prescriptions and the number of individuals receiving these prescriptions that we have. And I think in general, over time, you can see the number of prescriptions, the second column here is going up. So in 2012, 41,000 mental health prescriptions. In 2018, it's up to 73,000. That's quite a big increase in an annual way. I'll speak about this box at the end in a second as well. One of the other big factors that's worth pointing out to you is the population estimate. So we have the number of people aged 0 to 24 based on the national estimates of the population size. You can see that that's dropping over time. So the number of young people in NHS Grampian is reducing over time. So we go from about 170,000 down to 160,000 in the space of about 6 or 7 years. So the number of prescriptions going up in a reducing population, I guess, should be cause for concern. So I mentioned on the previous slide that we had a couple of months, one in 2019 and one in 2020, where we didn't have records for prescriptions. And what I've done basically here is I've taken the number of prescriptions for the 11 months, looked at the monthly rate, and then added on the additional month to give an idea of how many prescriptions we might be looking at. So there's a bit of a caveat there, but it seems to be fairly consistent with the previous year's trends of an upward trend. And then in 2021, we only have data for the first 5 months of the year. And there's also no mid-year population estimate that comes out the following year generally. So I can't tell you about the rate among the population, but what I can show you is on the far right-hand side at the bottom, the prescriptions per month. So for the months we have for 2021, you can see we're receiving 7,000 prescriptions for mental health medication in 2021 per month. So I'm going to show you some, some of the findings that we've got. Firstly, on school-based age groups. So obviously the pattern of these prescriptions changes as people age. Secondly, we're going to look at sex differences, so between boys and girls, and also age, because there is a pattern there as well. And then finally, we'll be looking at area deprivation. So this is the way we've cut the age groups. It's largely because the CAMS clinicians, a lot of their services are closely related with schools. So it's useful for them to see the data cut by school ages. So these are not equally sized groups, but I'll show you in a second a calculation of rates. But I guess what's most striking about this is that people aged over 18 are receiving more than half of these prescriptions for mental health medications. And it does increase with age, obviously. So I can give you the population sizes here differ, the number of years that we've grouped these into differs as well. But you can see that the rate of prescription by age is increasing here based on the number of children within these age groups in the population. It's a bit of a graphical representation of what I've just shown you. You can see that there's a big jump in the number of prescriptions as you go up in the age groups, particularly a big jump once you get out of school ages. And you can see on the right-hand side what we've got is the proportional spread of the different medications from the different sections from the BNF. And you can see how over time what's being prescribed to these people changes. So for those in the preschool and lower primary, so 0 to 7 years old, it's pretty much 50-50 for hypnotics, so things that are sleep aids essentially, and then medication to treat attention deficit hyperactivity disorder. And you can see over time that those become much smaller in the spread of medications that are being given, and the prescriptions of antidepressants seems to take over as you get older. And then we've got a similar chart showing you the breakdown by sex. So in the table on the left here, what we've got is we've split it, the number of prescriptions and the number of individuals who've received a prescription. So because this data is over a long period of time, the same person can appear in multiple different age groups and they can be given multiple prescriptions over time. So it's useful to see both sides of the picture to get a more accurate representation. So the number of prescriptions that boys receive is almost 50-50, slightly more than the females. But when you look at the number of individuals that are receiving these prescriptions, it's almost a 60-40 split for females. And as you can see on the right-hand side, the girls are in blue there and the boys are in yellow. The larger proportion of prescriptions given to girls doesn't really show up until they reach these older age groups. This is another way of showing the same thing. So it shows you, this is the annual number of prescriptions for boys and girls, and you can see the top three show the younger age groups, and there's consistently boys are having more prescriptions than girls. And then in upper secondary, it becomes about even throughout most of this period. And then for school leavers, there's a massive dominance of prescriptions for girls. So I'm going to talk to you about pardon me, deprivation. So this is a map of NHS Grampian, the region that we're in the northeast of Scotland. And it's showing you deprivation areas, how that's spread across the region. So the scale on the right hand side, number 1 in bright yellow is the most deprived areas. This is measured at a Scotland wide scale, and then the darkest areas, number 10, are the least deprived areas. Now, each of these areas has an equal number of people living in it, but it's not an equal size, obviously. So the rural areas appear much bigger in the chart than the city areas, which have many more people within a smaller area. So you can see that the deprivation in our region is very much concentrated in the city of Aberdeen, Peterhead, Fraserburgh, basically the towns, the higher population density areas. So this is showing you the crude rates of prescription by area of deprivation. So the table on the left, this shows you the number of prescriptions. So this is an average over the whole period, because it becomes quite difficult to measure a population from the population estimates over the whole period, because obviously people are aging each year. So that we've given you a mean population for each of these deprivation areas, and then also the mean number of prescriptions that we're seeing overall. So you can see, as I showed on the previous map, that there's many fewer areas that are considered to be in the most deprived areas, and that translates directly into many fewer people living in those areas. So we have, on average, for an average year in the last decade or so, there's around 2,200 people, or young people, living in the most deprived areas, and almost 10 times that amount living in the least deprived areas. And as you can see on the right-hand side, the rate of prescription shows this nice, well, not very nice, but shows a very clear social gradient pattern in here. So what we can say here is the absolute difference in prescription rate for people in the most deprived areas is just under half a prescription more per person than in the least deprived areas, and that's over twice the number. So the rate of prescription for people in the most deprived areas is over double that of people in the least deprived areas. There's an alternative way of calculating this that takes into account the number of people living within each area, but also the intermediate steps. So if you're looking at just a range, that gives you a good indication of the extreme difference, but there's a way of calculating this that gives you a bit more of an insight into what's going on in the intermediate levels of deprivation. But we can say over the whole period that people in the most deprived areas, for every 100 people, receive around 33 additional mental health prescriptions. And that's pretty consistent throughout this whole period. There seems to be an increase over time, and then maybe a bit of a dip coming into 2019, 2020. Pardon me. And then this, the relative index of inequality is another way of basically you take the previous score and then you look at the most deprived area compared with the average of all other areas by deprivation. And we can say that the rate of mental health prescription in the most deprived areas is around 45% higher than all of the average of all the other groups. That kind of concludes looking at these results, but I guess what's next? I think Jess mentioned our kind of continuing interaction with people, clinical leaders, clinical teams in the area to do with children and young people's mental health. So most of the prescriptions that I've mentioned to you are in the records. They're prescribed by general practitioners, but quite often that's on the advice of other professionals. So we'll be looking to engage with general practitioners, the people who are providing most of these prescriptions, and also giving this information back to CAMHS clinicians who, as Jess said, don't ordinarily get to see these sorts of information. And then we've also had some interaction with the local public health teams who are coming up with their children and young people's mental health strategy going forward. And then I guess the other opportunity, this is one small part of a bigger project. So we're looking at linking all of this insight into information to do with CAMHS referrals, other hospital episodes, crisis outcomes, as Jess said. And then I guess the big thing in an ideal world, we wouldn't be looking at prescriptions in isolation, but we'd also be looking at non-pharmaceutical interventions. So I hope that's something that we can do in the future. Anyway, that's my presentation. Thank you very much.